Good morning, everybody. Today, Amardeep from Usmania will be presenting the case. It will be moderated by Professor Ramesh Ardhanari, Professor Amanjeet Singh, and Professor Anand will be joining us shortly. I think it's all yours, Ramesh and Amanjeet.
Yeah, Amardeep, you can start with the presentation. I don't think we need any further introductions. Pradeep has done the needful.
Okay.
Please go ahead with the history.
Yes, sir.
Share your screen.
Good morning, everyone. Today I am presenting my case. She is a 45 years old female, resident of Jharkhand, presented with chief complaints of bleeding per rectum since last 3 months. Sorry. Coming to history of present illness, patient was apparently all right about 3 months back when she uh, when she uh, when she started having complaints of passing loose stools. Volume is not mentioned. 7 to 8 episodes per day of foul smelling stool mixed with blood and associated with mucus discharge, with 1 to 2 episodes at night leading to disturbed sleep. Patient also complains of painless bleeding per rectum, bright red in color, not associated with blood clots, scanty in quantity, but both during defecation and spontaneously, as well as staining her undergarment since 2 months. Initially intermittent and progressing to daily bleed for 1 month. She also gives a history of sense of incomplete evacuation and early morning diarrhea is present. I would like to know whether it was blood, mucus, stool, and the quantity. She also gave history of weight loss, which is 7 kg in 2 months, and also history of loss of appetite. There is no history of abdominal pain or distension, UGI bleed or vomiting, postural dizziness, syncope or blood transfusion, pain during defecation, urgency or incontinence, mass protruding per annum, fever, cough, icterus, respiratory distress or bone pain. There is no. I would also like to ask the history of any urinary symptoms or pain, perianal pain or discharge, tenesmus or skin lesions or joint.
But there is history of tenesmus, no? When you go back to your previous slide on the history, see that history of sense of incomplete evacuation. That is tenesmus. So you can't now say that there's no history of tenesmus. So be very careful when you write these things, because very clearly they have written that there's a sense of incomplete evacuation, which is tenesmus. Okay. Why did you ask for, why do you want skin lesions or joint pains?
Sir, I wanted to, I'm all for a patient has presented with bloody discharge mixed with stools and mucus discharge. So I want to ask for history regarding any inflammatory bowel disease. For extracolonic manifestation, I asked joint pain and skin lesion.
Do you think patients with IBD usually present with a 3-month history?
They can present, sir.
So let me welcome Anand Laxmanan, who has joined us. Welcome, Anand, from Stanley Medical College, Professor of GI Surgery from Stanley Medical College. Happy to have you.
Yeah, good morning. Good morning, everybody. Good morning.
So I agree with you that you would ask for this, but I'm highly unlikely that in just 3 months you will have history of ulcerative colitis.
Moreover, I think history, sir, is very typical of a malignancy. So whatever they made, so.
So your history is, what do you suggest at the end of the history? He has already given you a hint. So now you have finished the history, or is there some more history?
Sir, the medical history and past history is there. Past medical history, there is no history of any comorbidities like tuberculosis, heart disease, or thyroid disease. Past surgical history, she gave only history of tubal ligation 3 years back. Family history, they have mentioned not significant, but I will specifically ask for any history of malignancy in the family. Personal history, there is no addiction. Vegetarian diet, normal bladder habits, and sleep is disturbed. Menstrual history is not given, sir.
So any specific malignancy history will ask Amandeep, or any malignancy? Because in a patient who is young and with the comes with a colorectal cancer, I think specifically you should elaborate more on the family history.
So family history, I will specifically ask for colorectal, but I will also ask for any other malignancy, HNPCC related malignancy like stomach, ovarian, endometrial, or any urogenital malignancy also in first or second degree relatives.
Yeah, glad you use the term HNPCC because
Yes.
by using that term, you've shown that you know what you're talking about. So that is an important term to tell when you're asked a direct question. You need not tell that in the history, but when you're asked a question like Amanjeet asked, by using that term, you have shown that you know what you're talking about. So that's a good point. It's a positive point for your marks. So this is something that others should also remember. And you should also ask the history of chronic malignancy. Especially in which relatives would you ask for history of malignancy?
Well, I like to ask in first or second degree, like parents, siblings, or children's, or cousins or grandparents.
So suggesting siblings, is there anything else in the history you would like to ask for in this patient?
Siblings.
You have said that you are looking for history of malignancy in siblings. So if you are presenting the history, you are taking the history, is there any leading question you'll ask the patient?
I will ask any history of malignancy, means a colorectal or similar.
That we have asked. Any other history? I'm asking leading question because now the patient doesn't volunteer. So you would ask a leading question.
Any history of death due to malignancy in family?
No. See, she is giving history of 3 months history of bleeding per rectum. But then she might have bled at the age of 20, 25, which you have not asked. You have to, see, she may not remember. So you have to ask her whether she had bleeding at that age, because then that could suggest something else. So you should ask them that question specifically, because she doesn't tell. You should ask that as a leading question. Since they've not given the history, but put that in red. But I would like to know whether she had any previous histories of bleeding, which she has forgotten or to mention when she was telling the history. Many patients forget that they had bleeding for, say, 6 months at the age of 25, and then they didn't have bleeding again. Now, that could be the typical history of a familial polyposis. So that's why you want to know. Because if you look at her age, this is the typical age in which a FPC goes into malignancy, 42. This is about the age at which they turn. So you should ask that.
Yes.
Okay, carry on.
Coming to summary of my case, she is a 45 years old female, no comorbidity, presented with 3 months history of loose stool, 7 to 8 episodes per day, foul smelling, mixed with blood and associated mucus discharge, 1 to 2 episodes at night, leading to disturbed sleep associated with incomplete evacuation of stool. They also complains of painless bleeding per rectum, bright red in color, scanty both during defecation spontaneously, initially intermittent and progressing to daily for 1 month. Patient has a history of loss of appetite and loss of weight, which is 7 kg in last 2 months. My differentials, I would like to put first as carcinoma rectum as my first probable diagnosis. And my second probable second diagnosis, I will like to give inflammatory bowel disease.
So why have you put rectal cancer as your first diagnosis?
Rectum I have kept, sir, because patient gives history of rectal symptoms like incomplete evacuation of stools, early morning diarrhea, and patient is also having passage of fresh bloods and blood mixed with mucus. Malignancy I am suspected because she gives significant history of weight loss and loss of appetite.
You could have asked another leading question, which also would be important in this patient. What is that? Ask for a history of constipation. Isn't it? See, if suppose it instead of a lower rectum to an upper rectum or a rectosigmoid growth, she could very well have all these symptoms, but there may be a history of constipation, there may be a history of intermittent intestinal obstruction. So you should ask the leading question of intestinal obstruction, because that also will help you to decide on your line of management if there is or there is no obstruction. So again, I think it's a very important leading question to ask. Amandeep and Anand, you have any questions on the history?
Yeah. Okay, what is spurious diarrhea? What is spurious diarrhea?
Spurious diarrhea means the patient will complain of diarrhea, but the diarrhea will not contain mostly of stool. It will contain of blood mixed with mucus and secretion, and it will be small volume, sir. Uh, and mostly they will have early in the morning. It is seen in rectal irritative pathologies.
Did you ask this patient about that spurious diarrhea history?
Yes, sir. Actually, they have given this uh, uh, early morning diarrhea. That's why I asked whether the diarrhea was associated with blood, mucus, or stool, and any quantity of the stool, sir.
I think
Amandeep,
history is
any
very clear,
questions?
maybe. Yes.
Any questions? Or shall we move on to the examination?
I think we can move on, sir. We can discuss the
Okay.
management.
Okay, go to the examination, whatever you want to tell us. What is the examination?
Coming to the general examination, patient is conscious, cooperative oriented. She is a well-built and nourished. ECOG is 1. BMI
What
is
is-
21.
When you say ECOG, what is the full form of ECOG?
Eastern Cooperative Oncological Group.
Okay, Eastern Cooperative Oncology Group. Okay. When you say 1, what does it mean?
1 means she is able to carry out all her daily activity with mild restrictions, sir.
Suppose she was able to carry out all her activities without any restriction, what would you have classified it as?
0, ECOG 0. Means
So
there
you
is no
must-
change because of the disease pathology.
So then you have to, that's why you have to remember that ECOG starts with the first score of 0. It doesn't
0.
start with a score of 1. So when you
Yes,
say
sir.
1, that means there's some restriction in activity. So what is that restriction in activity that you think? Have they given any hints that what is the restriction in activity?
Restriction of activity they have not mentioned specifically, but she have to pass the stool for 6 to 8 episodes per day. Also, nighttime diarrhea is there, sir. So that will lead to her change in lifestyle, sir. That's why I have kept as ECOG 1.
Does a change in lifestyle make it ECOG 1? I'm not sure. I would ask my co-moderators to put in their work. I would say that if the patient is, say, at night, she requires some help to get to the toilet, or by the end of the evening, she's so tired that she needs some help to move around, then I would agree with ECOG 1. But just because she has to go to the toilet 6 to 8 times, if she manages to go on her own and do it, I would still say she's ECOG 0. My own feeling. And ask my co-moderators what they feel. Amandeep?
I think she might have to change her job profile and all. That also is a part of her ECOG 1 only.
Yes,
Because
yes.
she's going multiple times during the job, whatever she is
Was she
doing.
working? Was she working? Or she's a housewife?
They're not mentioned, I think.
So
They
they
are
are
not
not mentioned regarding occupation.
So that might be a part which they have
Yeah,
considered to be ECOG 1.
Yeah, but we don't know. From the history, I can't find anything to tell that she's 1. It looks like she's still a 0. Unless we have not been given some information. Obviously, you are working on a fixed history. You can't ask questions. So I understand your difficulties, but that's okay. But I was just thinking that to myself, that she looks like she's able, because you're right, she's well built and nourished. So that means that though she has lost weight, she's still well built. So she's probably doing everything by herself, I thought. So I would have thought it's 0, but 1 I will accept, because between 0 and 1, not much difference. Okay, go on.
Coming for vitals are stable, sir. She's afebrile. Pallor is there. There is no icterus sinuses, scrubbing or lymph node or edema. Breath holding time is 35 seconds. There is no palpable supraclavicular lymph nodes.
What you have said, palpable supraclavicular lymph nodes.
Yes, sir.
Your diagnosis, which you had said in the end of history, was C rectum. So why
Yes,
are
sir.
you telling us about palpable supraclavicular lymph nodes?
Considering it is to be malignancy, I would like to see as a metastatic status and basic examination for completion 6, sir,
What
for all malignancy.
if you had to give me a lymph node station, which one I would be happy to see? Not supraclavicular.
Inguinal lymph nodes, sir.
Yeah, If you had
Inguinal.
mentioned inguinal lymph nodes, or you have put it in red saying that no mention of inguinal lymph nodes, I would have been
Inguinal.
happy. I would have been happy because that is of relevance. Supraclavicular in a rectal cancer, I have never seen in my life. I can't remember. Amandeep and Anand, do you
Yes,
remember?
sure.
Yeah.
Huh?
Where in rectal cancer you will get inguinal nodes?
Yes, sir.
Where in which scenario of rectal cancer you will have inguinal nodes palpable?
Uh, uh, Sir, in lower rectum, sir, they will drain into uh, uh, external lymph nodes also, sir.
Does the lower rectum
Can
drain into?
can you be very specific? Is it lower rectum?
Can't be rectum. If it's inguinal nodes, it has to be some other organ, some other area of the bowel. What is the exact name for that? It's anal canal, isn't it? You have to
Anal canal.
specify anal canal.
Anal
So
canal.
it's in the anal canal that you can get lymph node. If the rectum comes into the anal canal, yes, you can get spread to the inguinal lymph node. So you should be specific and know this very clearly, the lymphatic drainage of the rectum. The rectum stops at the dentate line. So once it is above the dentate line, it will not drain into the inguinal nodes. It will go into the perirectal and then into the iliac and then into the aortic nodes. So it will not go into the. Anybody has any of the moderators disagree with me?
No.
Right, sir.
It's very much agreeable. And in that nodes, which nodes are more significant for inguinal nodes? I know we know that there is a horizontal group and there is a vertical group. Which nodes are more significant for malignant metastasis from, say, rectum involving anal canal or anal canal malignancies? That's it.
I don't know, sir. Specifically, I don't know.
I am happy you gave that answer. Rather than getting deeper into trouble, you have said, I don't know, which is fair enough. We won't hold it against you. Every candidate has an opportunity once or twice say, I don't know. And we are not going to penalize you for that. But suppose you had just taken a wild guess, we would have penalized you for that. So we are happy that you said, I don't know. So by and large, it is if it's a rectal cancer which is spread, you will find the vertical group of nodes above the iliacs, in the iliac. But the horizontal nodes you will find in the anal canal. And you will find more the medial group of
So, Amanjeet, you can also defend yourself saying that maybe as a general principle, I palpate the supraclavicular. But then it's obviously, like Dr. Ramesh said, you have to mention inguinal separately from the others. Because they are the ones which are most commonly involved.
And that is of importance, whereas the supraclavicular is not of importance in this case. Okay, move on.
Coming to the abdominal examination, on inspection, abdomen is flat with umbilicus central in position.
You can dismiss this slide that there is nothing positive in the abdominal examination, isn't it? One slide you can go through in 30 seconds by saying nothing is positive in this. Everything is negative.
On inspection, there is no positive findings, sir. Only previous scar of surgery healed are there. External general normal. Palpation, palpation soft, non-tender, no palpable organomegaly, hernial sites are normal. Percussion also, liver dullness with intercostal, liver span is 14, flank tympanic, no signs of any free fluids, sir. Auscultation, normal bowel sounds, sir. Coming to the digital rectal examination, perianal skin is normal sphincter tone is present. There is a firm, mobile growth palpable from 12 to 6 o'clock position at about 8 centimeter above anal verge, non-tender and does not bleed on touch. Upper extent of growth could not be made out. Glove stained with blackish stools. Vaginal examination findings are not given. Coming to proctoscopy, they have mentioned growth seen from 12 to 6 o'clock position. There is no active bleed. Proctoscopy, I would like to see morphology of the growth and surrounding structure.
What they've given, no, it is, go back to the slide, it is, what is, they've given you something, all the information that you need in the third line. Firm, mobile, growth palpable, 8 centimeters, non-tender, does not bleed on touch. Upper extent can't be made out. I think they've given you all the relevant information that you expect on a PR. The only thing they have not told you is probably, and they have also told you normal sphincter tone. So they've given you all the information. So to say that you didn't get the information would not be correct. They have given you all the information.
Sir, on proctoscopy, they have just mentioned the growth scenes. I would like to see whether it was ulceroproliferative or polypoidal, and how is the surrounding mucosa, whether it was normal or colitis changes, inflammation was there or not, or any other
Why even on PR you can say whether it's ulcerated or proliferative, no? You don't need a proctoscopy to tell that. You can tell it on PR also.
Here they have just mentioned that for mobile growth, sir.
How will you know that it is 8 centimeters from the anal verge?
Sir, 8 centimeter.
How do you measure
8 centimeter
that?
is.
No, how do you measure that? How do you measure that?
Sir, fingertips, sir. 8 centimeter will be just my fingertips.
It could be your fingertip, but for Adarsh Chowdhury, it might be the middle of his finger. He's a very tall man with big fingers. So that is not the way you measure the distance. How do you measure the distance? There has to be an absolute standard. What do you do? Can you just tell me in one line what exactly you do in the rectal examination? Since you obviously don't seem to be aware of it, the way to tell it is, I will do a rectal examination. I will keep the tip of my index finger at the lowermost point of the tumor on the rectal wall. Now, sometimes if it's a proliferative growth, the growth may hang 2 centimeters over the rectal wall. That is not important. That is not the lowest point of the growth. It is the point on the rectal wall that is important. So you put your finger at the lowermost point of the tumor on the rectal wall, and then you put your thumb at the anal verge. So if you keep your right thumb on the anal verge, and if you have your nurse, whoever is assisting you, standing by with a scale, and with your finger at the anal verge like this, the tip of the finger having felt the lowermost border, you bring your finger out and put it next to the scale and measure the actual distance from. So this is not done by most people. They just give 5 centimeters, 6 centimeters. This is not correct. These distances are very important in planning all your treatments. Therefore, you must measure accurately with a scale, and this is how you measure it accurately from the lowermost palpable tumor on the wall of the rectum to the anal verge, and you measure that in a scale. You must have a scale in your examination book, and then you should measure. That is the difference between what a general surgeon would do and what a GI surgeon or an oncologist would do. So you must be able to measure that distance from the anal verge to the tumor precisely. It could be 6.5 centimeters. Then you have to note 6.5 centimeters. And you must write it in the case sheet so that you know that on the first day you examined, this is the distance. So that will become a subsequent reference point for all future examinations. Anything you want to add to that, Amandeep or Anand?
Even beyond that, if you see, there is a functional anal canal. So the sphincter part, so as a surgeon, the part of the rectum available above the functional anal canal. So that is more important to the surgeon compared to distance to the anal valve.
So that you are anyway doing by proctoscopy and seeing where is the thing. So unless you know that distance and then subtract it from the distance to the Z line, you will not know that how much is the functional part, as you have rightly said, available. So you have to look at both distances, one by the proctoscope, which will be at the Z line or the mucocutaneous junction, and then the other one at the lowermost point of the growth. These two distances have to be measured very accurately.
So the principle is you have to feel the base of the tumor origin. That is what sir is mentioning. Sometimes it will be a frondy like growth. So when they use squeeze pressure, the fronds might come and fall in the finger, but that is not an accurate measurement. You have to feel the base and then you calculate. I have only 2 questions. What do you infer from this mobile? They say the growth is mobile. Why do you want to see this mobility in a CA rectum?
Mobility in say rectum, yeah, it will be suggestive of whether it is free from the surrounding structure. A fixed growth will suggest local, means advanced disease or infiltrating to surrounding organs.
Okay, how
Okay.
does, yes, sir, please. Ramesh.
No, I agreed with you. I agreed with him. That's why I nodded my head. Nothing
Yeah.
else.
8 centimeters from anal verge, what is your inference? Why do you want to measure this 8 centimeters or 5 centimeters like that?
Means origin of the lesion at the level of rectum, whether it is mid rectum or lower rectum, sir. It is
So
8
by
centimeters. It is just at the mid rectum, sir.
okay. How do you mathematically demarcate the rectum, middle, upper, and lower? What is lower rectum measurement? Middle rectum and upper rectum.
Usually from anal canal after excluding the from anal verge after excluding the anal verge, the for 4 centimeter we will consider as lower rectum. 4 to 8 centimeter.
4 is
Yes,
it?
sir. From anal
Verge?
verge 8 centimeter or from anorectal junction 4 centimeters, sir.
Usually rectum is 15
What
centimeters.
is it is upper rectum, mid rectum, lower rectum.
Lower rectum.
Okay, so what are the distances for each of these areas? Okay, let's go back to some little bit of anatomy since we are having some time. Where does the rectum begin anatomically?
Well, it begins at the anorectal junctions.
No, rectum doesn't begin at the anorectal
Upper
junction.
Sorry, upper.
Yeah, where does it begin?
Rectosigmoid junction, anatomically we can see it as a third sacral vertebra.
So that is the correct answer.
Which
The
sacral vertebra? Which sacral vertebra?
Is
There
it,
are specific demarcation for everything. Which sacral vertebra? Rectum begins.
Third sacral vertebra, sir, upper border where the rectum's takes in. Sigmoid will join the sacral vertebra, sir.
Yes. No, it will not join the sacral vertebra. Sigmoid doesn't join. The sigmoid colon, as it goes down to becoming further rectum, opposite the third piece of sacrum. That's how they say, third piece of sacrum. It will become the rectum. So how far is that from the anal verge generally? On an average in a sized man?
It ranges from 12 to 15 centimeters. Sir.
It is 15 centimeters, let us say. So very easy to remember. Upper, mid, and lower, 15 to 10, 10 to 5, 5 and below. Easy to remember. And when we say the areas of the rectum, when we say lower rectum, we include the anal canal in that, usually. We don't differentiate between anal canal and rectum for the lower rectum. We say it's 5 centimeters from the verge. And of course, the histology may change your approach, but by and large, this is how you classify it. Okay. So this is, you feel is a mid rectum. Okay. It is not actually in the mid rectum. It is ending in the mid rectum, isn't it?
Yes, sir.
You felt at 8 centimeters the end of the tube. So it is ending at 8 centimeters. So it is ending in the mid rectum, but you don't know how far above it is coming from because you couldn't reach and you have not done any scopy so far. Okay, so we have a tumor that's reaching up to the mid rectum. Mainly from 12 to 6 o'clock, you said. So it's on the left side of the rectum, hemirectum. Am I right?
Yes, sir.
So it's on the left hemirectum. So it's covering the full left hemirectum. Right hemirectum is free.
Yes, sir.
Okay. Okay. Now, are you changing your diagnosis or the diagnosis remains the same?
It will remain the same, sir.
Yeah, but your IBS goes out of the window, isn't it? Or does it? Or does it? I'm saying. Why? You could have a malignancy developing on an IBS. You don't know.
Yes, sir. It is not a diagnosed case, and she only presented with 3 months.
So you think it's unlikely. So you can say it's unlikely now to be.
Unlikely.
So we feel a big growth in the rectum. So it's all fits in with the history of 3 months, loss of appetite, loss of weight, everything. So you think it's now the diagnosis is a cancer rectum which extends up to the mid-third. You don't know the upper extent of the tumor. That is your complete diagnosis, and with no clinical evidence of metastatic disease. So the complete diagnosis when you tell should include these terms. It's a cancer rectum extending up to the mid-third of the rectum from above. We don't know what is the upper limit. It's mainly on the left side, left hemirectum, and clinically, there are no metastases. That means the liver is not enlarged, no nodules, no aortic nodes you can feel, and clinically, you don't think that she has a metastatic disease. So that's how you should tell the clinical diagnosis. It should be a complete clinical diagnosis. I see a lot of students who just say CA rectum. Then I have to ask them, is it metastatic? Where is it? So once you say this, you know what you're talking about. You have conveyed all the information to the examiners. And
Dr. Amarjeet, can I ask a question? Why did you look for a normal sphincter tone? What is its clinical significance?
Clinical significance means if I have to plan for surgery, sir, in a older patient, if there is no sphincter tone, I will not consider for any sphincter saving surgery, sir. I will offer them the chance of APR, sir, in such cases.
Very important, sir.
So you want to know the sphincter tone before you begin the treatment. So this is a very important point which Anand asked, and you have explained very well. So we are very happy with your answer. You have told very correctly. Because if there's no sphincter tone, if the sphincter is already involved or it is destroyed due to... See, it may be possible that she's got a third-degree perineal tear from multiple delivery. And so the sphincter is gone. That patient may not be suitable for an abdominoperineal resection, for a sphincter saving resection. So you're right, and we are happy with your answer. Go on. Now you've given the diagnosis. Now, next question, we are 8:30, so we'll start. What is the investigation that you would like to do? We want to spend half an hour at least on management.
First, I would like to do blood investigations. I would like to do competitive hemograph. I would like to see the HB.
Can we have the investigations? Yeah. Yeah, there you have the blood investigations.
Hemoglobin, they have mentioned 8.1. It is on the lower side.
So
total counts and platelets. Yes, sir. Total counts and platelets are within normal limits, sir.
Okay. Next investigation, what do you want?
RFT, sir.
Renal function test.
Renal function test. Urea creatinine is within normal limits. Electrolytes are within also normal limits. Sir.
Next, what else do you want?
LFT.
LFT, please.
Here, LFT is also within normal limit. PTINR also 0.98, sir.
So everything is within normal limits. All the blood tests so far have been within.
Anything specific you want in LFT?
Sir, tumor markers, I would like to see CA
Anything
levels.
specific in LFT?
LFT, not tumor marker. LFT.
Albumin, sir.
Yes, to see the nutritional status.
Nutritional status. Albumin is 4, sir. With normal.
And we would, our LFT would always have a gamma GTP. We always finish it with a gamma GTP. So here they've not done, but we would always do a gamma GTP in our LFTs. It's part of the LFT in our workup. So we would know. Sometimes that can be elevated isolatedly in a multiple secondaries, which any SOS is a liver. Anyway, that is not important. If you don't say it, it will not be held against you. Next.
Tumor markers, I would like to see, sir. CA level.
CA. Does she have a CA level?
CA is 5.8.
Is it normal or a little high or is it a little low? What is it?
Mildly elevated, just at the upper limit of normal, sir.
Yeah, mildly elevated. It's just at the upper limit of normal, but it's mildly elevated. Yeah.
Yes, sir.
Then?
I would like to get I would like to do a USG abdomen and chest X-ray, sir. That's my basic evaluation workup, sir.
Straight away a chest X-ray and ultrasound. Anything else?
Colonoscopy, complete colonoscopy also I would like to
I
ask.
think that's what you do in the OPD, isn't
No.
it? Sitting there.
Yes,
You
sir.
would ask for these blood tests and then send the patient for a scopy and a biopsy.
Okay.
You must say this, colonoscopy and biopsy.
Right.
Yeah,
Yes,
so
sir.
this is what you
Colonoscopy
would
and
do
biopsy.
in the outpatient. So please use whatever you do in the outpatient routinely. So we won't do ultrasound and this thing, just X-ray first investigation. We would do ultrasound, a colonoscopy and a biopsy on the first thing. So is
on
it a good?
colonoscopy,
No harm in saying that doing a proctoscopy, you can take a biopsy in this case.
Yeah,
If
also,
the
you can take a
tumor-
biopsy.
Yes.
proctoscopy and biopsy first.
Also possible. But do you think this is a good colonoscopic report?
Correct. I wanted to ask this question. Do you think the report is complete or?
Growth motility. No, sir. They have not given the proximal and distal extent of the growth.
So this
in the
is
report.
often done because the medical gastroenterologist has no idea of the importance of in a rectal cancer of what is the proximal limit and what is the distal limit.
Okay.
So he just writes growth in the mid rectum. It means nothing to you. You wanted to know exactly how far from the verge it is based on a scopy. You wanted to know what is the upper limit of the growth because obviously they have passed the growth. They've gone into the ileum. So they are writing on the terminal ileum, but they're not written to you what is the length of the growth. Because all these are important things which you would like to know. And you don't know whether as it goes up, this left rectal growth becomes a complete circumferential growth. So all this should have been commented. So this is why I keep telling out of the context of this presentation, but surgeons must do their own endoscopy. There are 2-3 places where they should do it. In a CA stomach, before deciding on what operation to do, and in a CA rectum, they should do their own and make their own measurements and keep it ready before they take the patient for, and not rely on some colonoscopic report that has been done by a medical gastroenterologist who hasn't given, or you train your medical gastroenterologist what you expect. So you tell them 5 times, this is what I expect, then they'll start giving you that. So you have to have either this or that. So this is an incomplete colonoscopic report and it doesn't tell you the details. Okay. So they've taken, and they've not written whether they've taken biopsies. See, normally if they've taken biopsies, they've taken multiple biopsies taken. They've not written there multiple biopsies taken. So, but they have done it obviously, and there you have your report.
Report is well to moderately differentiated adenocarcinoma, sir.
Okay, now you have your colonoscopy, where all you know is that it's in the mid rectum, which you know before the colonoscopy. All you got is that you got a well to moderate differentiated, which you, as Amanjeet said, you could have done by a proctoscopic in the OPD. When you did the proctoscopy, you would have taken a punch biopsy and you would have had the same report already. So with this, what are you going to do? Now here we come to the actual nitty-gritty of what you will do as investigations. And this is where you will pass or fail. So far, we have done very well. But the next few minutes are going to decide your final result.
I would like to do USG abdomen and X-ray chest, sir.
Okay, USG abdomen is normal. Do you have a report? There, it's all normal.
Yes, sir.
And X-ray chest, do you have an X-ray chest? If Sitaram is your examiner, you should say X-ray chest. Rest of us, we don't bother too much.
X-ray chest was normal only.
It's normal. Okay.
X-ray chest is normal. Then I would like to go ahead for further radiological investigation. I would like to see CACT of the abdomen, abdomen, pelvis, and chest, and also MRI pelvis, sir. Or local
So
staging of the
you want to do both the investigation. So now you give
Yes,
your
sir.
defense for doing both the investigation. Give your defense. Why you
first,
see you are going to cost the patient now double the money. And MRI
Yes.
will cost about 6,000 to 7,000 rupees, and CT will cost 6,000 to 7,000 rupees. Why you want both? Defend it.
First, regarding CECT, sir, CECT is a good basic investigation to rule out any metastatic disease in the liver and in the chest, sir. But it does not give a better idea regarding soft tissue in the pelvis, that is rectum. For rectal staging, that is local staging, MRI is proved to be a better investigation regarding T stage and N stage and involvement of the mesorectal fascia.
What is your evidence for that?
Sir, evidence comes from the magic trial, sir.
Magic trial?
Magic.
Sorry.
What does the magic trial do? What does the magic trial show? What is magic trial? If you are told this, David Cunningham will kill himself. He is the lead author of the magic trial. He'll kill himself. The magic trial was
Maybe
for OG junction tumors.
Sorry,
Nothing to
it
do
is
with
not.
rectum.
Maybe that
Not
also
for-
starts with M. So
It's
you
always
got,
started with M.
you got confused, huh?
You got confused. Magic trial is for OG junction.
Yeah.
M.
It's a planet. It sounds like a planet.
Yeah,
Mercury.
Ah.
Mercury trial, sir. Sorry, Mercury
Okay.
trial.
So at least you took that hint. Okay.
Yes.
So what does the Mercury trial tell you?
Mercury trial, it shows that the preoperative MRI of the pelvis shows as good result for T staging and N staging and margin involvement as compared to a pathological staging of the same tissue, sir.
As good as a pathological staging. Okay.
Yes,
So
sir.
if you have attended any of Gina Brown's lecture, she is the lead author of the Mercury trial. She actually gives you the MRI on one side, and then on the other side, she shows you the same level, the cut pathological specimen, and
Yes,
multiple, and you will see that it's so accurate that in our hands, the MRI has now become the standard for doing the local staging. So I agree with you that most of us would do an MRI under CT for the distant metastasis. But there are many radiologists who say that with the CT today, we can give you equal results for liver mets and lung mets with the modern CT machines. I don't know, but if you say that and if you say that in the exam, I will not disagree with you. I don't know about others. I will agree with you because that's what the radiologists say. So, what in the MRI are you going to look for? Do we have the MRI image? Do we have the MRI images? So there you have some MRI images. They'll show you the MRI images. Tell us what you see.
Yes. It is not moving. Okay.
What sections are these?
These are T2 sections, sir. T2 image in coronal section.
Coronal. So these are coronal sections. Okay.
Yes, sir.
Would
Sorry,
you like to
axial section, axial sections. These are axial sections.
Axial section. Okay.
Yes,
So
sir. Sorry.
longitudinal cuts. Okay.
Yes, sir. Yes.
Would you like to see this first, or would you like to see the coronal sections first?
I will have to see the coronal sections.
So can you show the coronal sections? Yeah, there it is, coronal. Okay, there you have the. No, not yet.
Control is not working properly.
Okay, so you have the coronal sections. Can you freeze it somewhere at one level and then he can move it himself up and down and see?
Yes, sir. I'm able.
Identify some of the prominent landmarks that you see in this image. Here, what are the prominent landmarks you see?
This is the rectum, sir. Rectum. This is levator ani muscles. This is the.
Is that the rectum?
This.
That is the rectum.
Okay, the rectum, I agree. Okay. What are the other structures you're seeing there?
About this is uterus. This is rectal continuity.
Okay.
There is filling defect seen in this part of the rectum. I'm not able to appreciate well in these sections. This
Yeah, this is
this sir.
Yeah,
This is the growth. We can see on the left side. Here I'm able to see in the, I'm only able to appreciate that it is still in the uh, lumen. I'm not able to appreciate whether it is involving mesorectum in this selected cuts.
Some more cuts you can probably see and then decide. One cut you may not be able to see.
This in the mesorectum, I'm able to see appreciate this lymph node.
very good. Nice point.
It's a big lymph node. It's a fairly
Yes,
large one. So
yes,
it's a
sir.
large, yeah.
This also, whether lymph node is there or not, I'm not sure. Then here also in the lower part also one lymph node is visible. There are multiple lymph nodes in this section 1, 2, 3.
Yes.
Yeah.
Is there a clear plane between the?
Where is the levator ani in this picture? Where is the levator ani?
This sir.
So where is
Yeah.
the growth now? Above the levator ani or at levator ani or below?
Sir, above the levator ana. This is levator ana. This is the lower rectum, and if we go upper section, the growth is starting in this section, sir. It is
Yes.
this
correct.
is
well
away
above,
from the
well above.
yes, sir. Well above, sir.
Is there
And
a plane between the growth and the uterus that you showed us?
here small plane, sir. Only in this part, suspicious breach is there, sir.
Yeah,
small.
at that one point it seems as if it is breached.
Yes,
But
sir.
okay. Okay.
This looks normal. You can see in this picture, it is reaching up to the peritoneal flexion, the upper part.
Yeah. Yeah.
So here. So it's reaching up to the this peritoneal flexion.
Yes.
No, I think
So what are those? What are those snake-like structures? Do you think they are important?
Yes, sir. These are extramural vascular invasions, sir.
Yeah, it
That is
looks
tumor
like that.
invasion.
These
Yes, sir.
looks like
Looks like.
EVMI. Yeah,
Yes, sir.
it doesn't it? So this is the
Yes, sir.
greatest advantage of MRI over CT, that you can pick up these EVMI. Okay, that is one thing. Second, can you see the urinary bladder in any of the cuts? So far, I'm not seen there. Game and I don't know when that is. So there, where is it? I'm not seeing it yet.
Yes. This.
Okay. So, looking at this urinary bladder, you saw that bladder there. What does it seem to be the relationship to the growth? That's the bladder. So what is the
Yes, sir.
relationship to the growth?
Here, suspicious of some
Yes,
losses.
go ahead.
Yes, sir.
Yeah, so that at that one point it seems as if the dome of the bladder and the
Dome of the bladder.
sigmoid colon seem to be very closely, maybe even adherent, but not perforated. There doesn't seem to be a
Yes, sir.
fistula, but it
Yes,
is
sir.
very close to each other. So that is something you should tell when you see these images. Okay, so based on this, what is your now staging of the disease? Do we have the CT cuts to show us some CT cuts, liver and all that?
Yes, I'll show the CT now.
Yeah.
This
So
is
what does the CT cuts show you?
this is exit city portal phase. Uh, uh, there is no gross lesions in the liver, sir. There is no ascites. In the soft tissue lung window, I am not able to appreciate any mass lesion. And no, I don't have the control.
You don't have the control, but can you see something which is
This
obvious
is
or is not obvious?
city window of the lung. I'm not able to appreciate any lesion in the lungs,
Secondaries.
sir.
Yeah, okay.
Secondaries. Yes, sir.
What about the rest of the abdomen? What are you looking for?
Rest of the abdomen, I am looking for first is the liver, any
That you already
metastatic
said, liver
deposit.
has no mets, no mets, okay.
Metastatic, then any para-aortic lymph nodes, any peritoneal deposit, visualized peritoneal deposits. Then comparing to the MRI finding, I would like to see the bladder and uterus also.
Anything else? What is it on CT? Can we have some the coronal sections of the CT? What is it that you're looking for?
Yes, sir.
Yeah, you're looking for something. What is that?
I'm not able to appreciate any inguinal lymph nodes.
Not nodes. Look at the abdomen. See,
Uh,
in a
bowel
sheer
distension.
rectum. Yeah, you want to know whether there's
Bowel-
obstruction, small
obstruction.
intestinal obstruction, whether there's features of subacute obstruction.
Okay.
There doesn't seem to be any fluid levels, no obstruction.
Fluid level,
no,
yes, sir.
yeah, but some of the bowel loops are a little dilated, but no obvious obstruction. So this
Obvious,
is something that you should comment upon.
Yes, sir.
How is the cecum? You should also comment on the cecum in a rectal or a sigmoid cancer, no?
Yes.
What is there in the cecum? Is there anything in the cecum? What are you looking for?
Cecum appears normal, sir, not distended. Large bowel obstruction, distension of cecum also I would like to say some.
So there is no cecal distension.
Distension. Yes,
normally, what would be the upper limit of your cecal size if you measured it on a normal and between distension and normal? What is the upper limit of the cecal size?
Normally, it will be around 6 centimeters, 6 to 9 centimeters.
So it's above 9, it will be a pathologically enlarged cecum. And if the transverse colon is above 6, then that will be pathologically enlarged transverse colon.
Enlarged.
You have neither of them here. Okay, so
yes, sir.
No liver secondaries, no obstruction, nothing. Okay, now you got your CT, you have your MRI. What is your staging based on CT and MRI?
Coming to the staging, CT, I'm not.
Forget the CT. You have the TNM from the MRI.
Regarding T staging, there was suspicious involvement of the uterus in one section. So I will T4s and nodes. I have calculated minimum 5 nodes, sir. So it is a T2 disease, sir. And there is no evidence of any
N2 disease.
N2 disease. And on metastatic CT, I did not find any suspicious metastatic deposits, sir.
So it's a T4 N2 M0 in your opinion.
Yes, sir.
Do we need a contrast MRI or plain MRI is good enough for rectum?
So for MRI rectum, plain MRI is good enough. Only T2 weighted images, selected 2P weighted images of rectal protocol. I will like to see, sir.
For all cases.
Yes, sir.
For all cases, you need a.
If you just excuse me for 1 minute, I have to pick up my breakfast.
Hello.
So for all cases, you need a plain MRI, or do you need contrast in some specific cases? Okay, so for restaging MRI, you usually need a contrast. For de novo rectal cancer, you can go ahead with the plain MRI. And for lung metastasis, do you need a chest CT with contrast or a plain chest CT?
No, sir. Fine plain CT will be good enough. If there is a lesion present, for characterization of the lesion, I can do later on. I can do a contrast CT.
So
Otherwise, a
NCCN
plain CT
recommend
is
even a
also good
plain
enough.
CT
Yes, sir.
if you're getting a MRI abdomen and pelvic. Okay, so we can just show the report. I think already 5 minutes left, so we
Yeah,
can go
show the
with
reports.
Can you just
Okay.
share the
MRI.
screen and show the MRI and CT
No, you
report?
forget that. We will assume it's T4N2M0.
Yes, and no metastatic.
That is M0. So
M0.
what treatment are you going to tell this patient?
Okay.
They have written EMBI negative. So
Okay.
for them, because that they have made it T3A, but I agree that toward the uterus on one side, there does seem to be a doubt. Yeah. Okay.
Okay.
What did you do for her now?
Regarding the management, first I would like to discuss the case in MDT clinic, and then I will go for the management. The patient is having T3 disease with N1. As per the reports, the patient requires neoadjuvant therapy before undergoing any surgery, sir. So for her, I would like to go. I would like long-term uh, chemoradiotherapy. I
Long
would like to
course.
Long course.
long course. Sorry, long course. I will like to give 54 gray of radiation along with abscession or fluorouracil, and surgery will be done around 8 to 12 weeks after the finishing the course. Also,
Why not
after
TNT? Amanjeet, sorry to interrupt. Why not TNT in this patient? Is the ideal case for TNT?
TNT is ideal, sir, but our institution we are giving long course therapy.
What does NCCN say in this stage? T3N1.
T3N2 actually. From what
N2
we
actually.
can see.
Actually, it's T4A and 2 because even the peritoneal reflection we could see that.
See, I would
was
disagree
involved.
with the radiologist report. Yes.
Yes,
Uh,
T4A and 2. So, what does the NCCN guidelines say?
we don't know, sir, specifically regarding NCCN.
You must read NCCN
You must
guidelines.
know. Yes, yes.
You must
How
read
do you
NCCN
ascertain the
guidelines.
end? How do you ascertain the end status?
Sir, N status is regarding the lymph node, sir.
Yeah. What is N1? What is N2?
N1 is 1 to 3 lymph nodes. N2 is N2A is 4 to 6 lymph node, and 6 or more is N2B, sir.
No.
NCCN.
The question which Amanjeet asked is very important. This
Tumor
patient you will
deposit.
take for neoadjuvant or you will take for total neoadjuvant? Standard
So
neoadjuvant or total neoadjuvant? What do you mean by total neoadjuvant?
Total neoadjuvant, we will give all the chemotherapy prior to doing any surgery, sir. Usually 6 cycles of FOLFOX will be given along
Only
with
chemotherapy?
radiotherapy.
Yeah,
Radiotherapy also, sir. Radiotherapy
so
also.
what are the standard regimes that you know in TNT? One or two regimes you can tell.
FOLFOX regime or FLAPOX regime or FOLFIRI regime also. Yes, sir.
Which they have used. So it's either Rapido protocol, it's a Prospect protocol, it's a Prodigy protocol. So there are different kind of protocols. So it's not in terms of FOLFOX or what they have used. So what is the advantage of TNT?
TMT advantage is we give all the chemotherapy before the start of surgery. So it will we can assess the we can assess the response of the patient and the tumor for
so
the
that you can do after
therapies, whether they have
that
and
will
also
do
it will show TNTs will show good pathological complete response. Also, the duration of
That is the important
duration.
point you have to tell, that you have to have complete response.
Response.
Don't say pathological, say complete clinical
Complete
response.
response, clinical response.
Clinical response in a
Yes,
higher
sir.
percentage compared to neoadjuvant. Yes.
So the
And
So what is
And-
the regime
hello?
that if you don't do neoadjuvant in your institute? Total neoadjuvant.
Total near.
no, sir. At present, we are doing a long course.
I know, Amardeep, but even if you are not using as a student, you should know what is the data
Yes,
on TNT. The main
Yes,
aim
sir.
of TNT is basically early control of micrometastasis,
Micrometastasis.
better compliance, because after the surgery, there is a lot of dropout in terms of chemotherapy.
Hmm.
The third main advantage, there is a lesser stoma time. So you give
Stoma
the
duration.
urgent treatment first, so that time for which the patient has to keep a stoma, that becomes less.
Less.
And the
Yes.
disadvantage is
So-
basically over-treatment. You don't know that the radiological staging is correct. So there are many
Yes, sir.
patients who are over-treated.
Yes, sir.
So coming to regime, there are some induction regime, there are some consolidation. So are you aware of those things, or
Anyway,
go
we generally use the rapido treatment, 4 to 6 cycles of Folfox,
Folfox.
then a short course of radiotherapy, 5 into 500 Grays, then another 6 cycles of to 12 cycles depending on the response of Folfox. And at the end of that, reassess with a CT and if necessary with a PET, and then decide on surgery. Now,
So
there
as
is
you
one reason why I will go for TNT in this patient. I don't know whether the other moderators will agree, but while it is 8 centimeters, it seems to be a very long tumor. You see, it goes from 8 centimeters and almost up to the pelvic reflection and above. So, you know, it's a long tumor in my opinion. So, I would like to go for TNT in this patient. She is
Yes.
42 and
Yes.
45, and it's a well differentiated in some areas, but only moderate. So differentiation goes by the worst differentiation that you identify. So it's a moderately differentiated carcinoma. So it is slightly worse. So with all this in picture and those big nodes, I would go for TNT. What about the other moderators? What would you do?
So even if you see
So-
the NCCN guideline for T4N2, they recommend doing a TNT. For
Yeah.
T3N1, they have written TNT and the standard treatment, and they have written preferred word for the TNT. For T4N2, they have clearly mentioned only TNT. So this is actually ideal candidate for TNT. So whether to give like
I think I agree completely with Amanjeet. We would send this patient for TNT.
yes, and in TNT, as Dr. Ramesh has said, there are different regimes. Rapido is basically short course followed by chemotherapy.
Delayed.
There is the PRODICE where they have used FOLFIRINOX followed by the treatment this surgery, and there is the prospect where they have actually done chemotherapy, Folfox standard, then reassessed. If need for radiation, they have added radiation. So there are different trials which you should see.
And you should
And
read
there are
about.
different advantages and disadvantages of using both induction and consolidation. So
And you
over
should-
just as a basic principle, if you are planning for a low rectal tumor where you are going for a wait and watch, then consolidation is better because the PCR rate, they are better with the consolidation. Patient who present with a bleeding or with a tenesmus, so which are symptomatic, in those cases, adding radiation first and then giving chemotherapy makes sense because the symptoms get relieved. And moreover, patients who are T4 MRF positive. So these are the patients where you are going in terms of a consolidation. Induction basically where you have a high risk for a systemic failure, like patient who have a high risk feature, EMVA positive, poor prognostic things. So those are the patients where you add for induction chemotherapy. So as a surgeon, if you say somebody asks you which one you like, I would like an induction because then after 6 to 8 weeks of radiation, you will be going in for surgery. Because in consolidation, if you see there is a long gap between the radiation and your surgery, so the planes will get fibro. But
I would actually prefer upfront chemo first
Yes,
because
yes.
these patients have you have to control the micrometastasis. So I would go for upfront chemo, 4 cycles of Folfox, then give a short course of radiation because that will disturb my chemotherapy schedule less than a full course because full course will take 6 weeks and then the patient has a longer toxicity. So 2 weeks, 5 days, and then 2 weeks recovery, and again you can continue with FOLFOX. At the second stage, even FOLFIRI may be added by in some aggressive tumors and then you reassess the patient and decide on surgery. As a matter of fact, we are now analyzing our data. I've just asked my PG to take over the data. The last 7 patients we have given total neoadjuvant therapy. They have not come back to surgery because there's complete clinical response. So we are all on the wait and watch. So it's an extraordinarily good and powerful regime. But the patients have a lot of toxicity, but then at the end of it, they tolerate. Up front, when you did the biopsy, will you ask the patient to undergo an MSI and an MMR
That's a very important question.
testing
Yes,
of
sir.
the tumor?
Yes, sir. She is less than 50 years of age, so I will compulsory ask for this MSI testing for this patient, sir.
If
Why?
the age is 60,
Why?
Yes, sir.
Amardeep, if the age is 60, you will not get it. What is the basic protocol these days?
For all colorectal malignancy, we have to get a MSI testing done, sir. But
When?
yes, sir.
When should you do the MSI and MMR deficiency testing?
Since on the first pathological
Yeah.
specimen we can do, sir.
Yeah, so now the movement is towards at the time of the first pathological. Why? Why?
Especially it will help me to give stage 2 disease, which high MSI high patient, they have good prognosis, so they don't need chemotherapy. While MSI low patient, I will like to give chemotherapy.
So let us say,
that is-
say that this patient is MSI high and his MMR is deficient. What will you do for this patient? Is there any alternative lines of treatment you know for these patients?
There was such a published study in which they have shown 100% results. So what do you see in MMR? What do you see? What is this test MSI?
Microsatellite instability on IHC, we have to see, sir, whether it is staining the protein. We have to see the MMR.
So there are four genes which are seen. So
yes, sir. MLH1, MSH2, MSH6, and PMS2, sir.
Yeah.
So if these are absent, we call it a deficient MMR or a MSI high.
Is MMR deficient better or MMR proficient is better for the patient?
Mutation will not produce the protein, sir. So deficient will be this mutation positive.
No, deficient is better or proficient is better?
Which one is more common?
So very simply, 90% of the patients at least in India will have MMR proficient. So they will not be deficient. So, but MMR deficient is the better prognosis tumor. And I asked you a question, what other treatment? Well, last question before we open it to the house for comments. Last question. What are the MMR deficient and MMR deficient and MSI high? What alternative treatment is available?
I think he does not know. It's immunotherapy.
Immunotherapy and
immunotherapy.
2 studies, which one had 25 patients, the other had 14 patients, and they had 100% complete response, which has maintained at a follow-up of maximum of 4 years and a minimum of 2 years. The responses of complete just received 6 injections of immunotherapy over a period of 6 months. No chemo, no radiation, no surgery. And the tumors are completely vanished. Very small percentage will fit into this, but you should do it upfront so that if you catch one of them, they can have very easy treatment.
This is called universal or reflex testing. So it is recommended by NCCN all newly diagnosed colorectal cancer patients.
So we routinely do now.
Yes.
As we send the biopsy, we send it, because we don't do it here, we send it to Ranbaxy Specialty Laboratories for the MMR and MSR. So we routinely do it at the time of biopsy.
Suppose after this therapy, you find partial response after evaluation. What will be your What will be your management?
Which response? You're talking of immunotherapy or you're talking of neoadjuvant?
Neoadjuvant.
Neoadjuvant. Now that's a clarification. So neoadjuvant, what will you do? Partial response is there.
If partial response is there, I would like to go ahead with a surgery, sir.
What surgery?
I will like to do low anterior resection.
So this patient may see, this is the problem that last time also I pointed out when the CA rectum was presented, and this time also I'm pointing out that you have not restaged the disease. You have not re-imaged the patient. You have straight away said, I will do surgery and I will do a low anterior resection. Now, let us say you restage the disease and the tumor has now come down to 2 centimeters from the anal bulge. It's really progressed in spite of all your. You can't do a sphincter saving surgery. So the first thing you have to do is say that at the end of neoadjuvant, I will restage and re-image the patient before taking a decision what to do.
Yes.
Last time also I pointed this out to the presenter and he also missed this. You're also missing it. I don't know why you don't think of this restaging. Is it maybe because your oncologists do it and send it to you, so you don't do it, but you should know the theory. So you have to restage and re-image the patient. So the imaging is for something else and the staging is for to see whether it has progressed or come back. And imaging is because it will help you to plan your surgery. So you have to re-image. Now suppose the patient, you do a CT, shows multiple liver mets. Are you going to do a anti-aging? I won't do.
There could be progression of the disease also.
Yeah, so you have to re-image and restage the disease. So this is very important. So you must not forget this point. You both the candidates who are in CA rectum, last time also were moderating the CA rectum, both of you have forgotten to do this procedure. So with this, I think we will stop and we'll ask the other people who are in. We have Pradeep Rabela, Shastri, Kapoor, Deepak Govind.
Yes, so just for restaging MRI, you get a contrast MRI, you get the diffusion weighted the images to see whether it's an active tumor or just scar tissue.
So we open it to the panelists.
Yeah, Amardeep, I think you have done overall well. There's no problem. We have, I don't think there is any more criticism from me. I think all the moderators have highlighted your deficiencies and corrected them. Now we have Dr. Deepak Govil, Dr. Shastri, Professor Kapoor.
I think Kapoor wanted to say something. He has highlighted.
Yeah.
Morning, Pradeep. Good morning.
Good morning, sir.
VK Kapoor here. Yeah. So first is the anatomy. This is one area where the anatomical anatomy and surgical anatomy are different. For us, the landmarks are, one is the buttock level that you take care of by placing the patient in the left lateral position with the knee flexed. Second is the anal verge, which is the point between the perianal skin and the anus. Next is the dentate line. Now for the anatomists, dentate line is the landmark. But for us, it is not the dentate line. It is the anorectal ring, which is the innermost fibers of the levator ani, that is the puborectalis. So between the puborectalis and dentate line is the surgical anal canal. That is why when we do a double stapled restorative proctocolectomy, we call it ileal pouch anal anastomosis. This anastomosis is a centimeter or two above the dentate line. Anatomically, it is in the rectum, but surgically, it is in the anal canal. So for us, the rectum is above the anorectal ring. That is the difference. Whenever you have a patient with malignancy who is young, less than 30, less than 40, even less than 50, the family history, it is not enough to say no family history of a similar disease or no family history of cancer. You should give more detail. You should say there is no family history of cancer of which organs? The genital organs in female, prostate in male, thyroid, colorectal. In first degree relatives include grandparents, parents, siblings, children, and grandchildren. You may also mention second degree relatives, which would include maternal and paternal aunts and uncles and nephews and nieces. You also need to ask and say that there was no death in either first or second degree relatives at an early age. The patient may not know whether the person who died had malignancy, but death at a young age should raise a suspicion, and then you should ask more. Irrespective of the age of the examiners, whether it is me or Amandeep, it is always safer to say a chest X-ray and an ultrasound first in any patient with cancer, and then go on to more expensive, invasive, and radiation-based investigations. Because in many malignancies, especially HPV malignancies, if chest X-ray or ultrasound shows a metastasis, then probably other investigations may not be required.
Well, what about biopsy? What about biopsy? Vinay?
Yeah, from the liver, it is very easy to get an ultrasound-guided FNAC.
No, from the tumor, will you do the biopsy first or will you do
Yeah. I'm saying as far as the metastatic investigations are concerned.
Okay. So you do the biopsy first from the tumor anyway.
Yes,
okay,
yes.
That's fine. That's what we wanted to highlight.
Yes, definitely. Because we must remember that although rare, sometimes you can have diseases like Crohn's, diseases like solitary rectal ulcer syndrome, diseases like tuberculosis, which can exactly mimic malignancy. So especially in a young patient where clinical picture is not very definitive towards indicating, and especially if you are planning to do an APR, most of us would not do an APR unless we have proven that it is malignancy. Anterior and low anterior resection, maybe yes, even if 2 biopsies are negative. And for CA rectum, I think more and more groups would prefer a CT chest and abdomen and MR pelvis rather than doing both investigations for all areas. So students, please send me a mail, vkkapoor.india@gmail.com, write rectum in the subject of the mail. I'll send you chapters on rectum from clinical and operative surgery books. Thank you. Thanks, Pradeep.
Yes,
I have one question, sir. So I have 2 questions. Regarding biopsy, sir, in a biopsy of colorectal malignancy, should we ask for MSI testing initially when they give biopsy, or later when examiner asks, sir? And second is regarding the treatment method, sir. In our institution, we are giving long course, but if NMC recommending only TNT in certain cases, should I say NMC guidelines or what we are following in our institute? Sir.
You can say what is standard. NCCN and ESMO. These are the 2 standard oncology guidelines across the world. ESMO is European Society of Medical Oncology. NCCN is the National Cancer Network. Okay. You can use either one of them. Now, there's no need to tell what you do in your institute because the examination is being held at a different center. So you will have different examiners. You won't have your examiner from your institute. So you can say what is given because many people may not agree with what is being done in your institute, but they will all agree with what is done by NCCN or ESMO. So you can use one of those 2 guidelines. The second question that you had on
MSI testing in biopsy.
Yeah, I think today you should do MSI and MMR up front because in the 10% of patients who have the MSI high and MMR deficient, you can give them immunotherapy. It's expensive, but if they may be willing to take a treatment which requires no chemo, no radiation, nothing, and almost guarantees a cure. So I think you have to do it upfront. Otherwise, you will miss the boat if you do it later because you wouldn't have given this treatment at all. So I think today, I think we should do it upfront. That is my opinion. You can ask the other moderators.
I think he's absolutely correct. You should know the NCCN guideline. NCCN guideline are like a Bible of surgeons. So you must be aware of that.
Amanjeet, there are 2 Q&A questions asked.
Amanjeet, the only problem is that the NCCN is like a sponsored Bible. So many of the guidelines there are sponsored by the companies who are sponsoring the people writing the guidelines, and they make so some of those guidelines.
Yes, sir.
I think
But
are not suitable for Indian conditions.
Yes,
the
sir.
ESMO, where they have got no financial interest, sometimes makes more sense to follow for Indian patients. And we can't hear you. You're muted.
You are not wrong in explaining to the examiners what you do in your institutional practice. But that is also a standard, but then you should know what other guidelines on date, theoretical knowledge at least, when you are asked to explain. Huh? So that's the thing.
Yes, you're not doing anything wrong for the patient by giving the standard treatment. But you should be aware of what is being done these days.
What about Shastri? Want to say something?
Yeah, Amardeep, you have done fairly well. In answer to your question, yes, you should know the standard guidelines, particularly NCCN, to support yourself in what you are saying. At the same time, and when you have options, say you have an option of induction chemotherapy and consolidation chemotherapy, you should know the differences between the two and the advantages and disadvantages at this stage as far as the expectations are concerned. Where you want a higher organ preservation, you prefer a consolidation chemotherapy. And still, you must remember that induction chemotherapy does have an advantage in personalizing treatment intensity on the basis of initial response. The differences at this stage are important because the final word is still not said. So you have the options. The current option definitely for a locally advanced tumor is TNT. But at the same time, you should know the advantages and disadvantages of both the options.
Deepak Govind?
There are questions from the audience.
I think it's
So-
been amply stressed that you should be aware of the present guidelines. TNT, I think, in a young fit patient, you would consider with a locally advanced lesion, you would consider a TNT. Whereas if it is not fit or comorbidities or other issues are there, then you can probably consider an ACRT or a long course. So I think even if you're not using, you should be fairly thorough with the present studies and the present treatment which is being given for these situations. Another, I think, which has been stressed by that restaging is very important. Clinical examination, restaging, MRI, ERG grading, all these things are very important before you directly embark on the surgical treatment. Yeah.
Yeah, that is, I think, the one point on which I would
Yeah.
try to penalize you. If your short cases go badly, you will probably do bad because you didn't restate. And that is a very important part of any cancer treatment. If you're giving neoadjuvant, not just for rectum, but also for esophagus, stomach, colon, anywhere you do, you have to restate before you decide.
Ramesh, there are two questions from the student. So first one is why we have to see coronal sections first in MRI. Is there any rationale?
No, nothing.
No.
I would actually, I mean, the spread to the lymph nodes, spread to the mesorectal fascia is easier seen on the coronal section than on the longitudinal section. So I think that is why we all see the coronal sections first. But if you see it reverse, as long as you see everything before making a conclusion, it is okay, as far as I am concerned.
Yes. So another is the role of PET-CT. I think Amardeep can answer this question. Role of PET-CT in colorectal cancers.
Routine role of PET-CT is not recommended in rectal malignancies, sir.
So where is it routinely recommended? Which malignancy?
Means other than colorectal, sir?
Yeah, other than colorectal. I mean, obviously. Any place where it is routinely recommended by NCCN? Well, this may be the last point that we make today. But CA esophagus is one place where you must do upfront PET-CT because it often metastasizes widely. So you don't want to do an esophagectomy or start on a neoadjuvant therapy in a patient who's got widespread lung or bone metastasis. So esophagus is one where it is recommended to do it upfront, but virtually no other it is recommended. But then all our patients come with a PET-CT done because they all have MBBS doctors who have no idea and they do think that PET-CT is the way to diagnose a malignancy now, which is a completely wrong concept, but that's what they do. So they do a PET-CT and they come with it. So we are helpless. We already have the PET-CT. So we then use it to guide us in whichever way.
Can I just add one thing? In cases where there's a very high CEA level, then you may consider a PET-CT if you suspect a metastatic disease.
Yeah.
So basically,
that would be somebody who's received treatment and then has a CEA level, or at the present, if he comes with a high
At the
CEA?
present, yeah. At the present, yeah.
At the present, yeah. Same thing with a high CA 99 level in pancreatic cancer. You would probably do a PET-CT to just make sure that there's no meds.
So otherwise, standard answer is any suspicious lesion on routine imaging, you get a PET-CT.
Yeah.
Anybody else wants to make a comment from anybody in the panel? Analysts? Yes, Amardeep, last question.
Regarding high CA level, regarding high CA level, what should be our cutoff for doing a PET CT? Because they have not mentioned, sir, what we will label it as high CA.
Nobody knows that, Amardeep. That is a gray zone. Nobody knows the answer. So I think I just had one clarification, Dr. Ramesh. So we were telling him that the rectum is 15 centimeter. So I thought the lower 3 to 5 centimeters is the
Is
anal
anal canal,
and then we
but-
start from.
Yeah, it starts as anal canal. As I said, anatomically it is anal canal. But the
Yes.
people measure it as 5, 10, and 15 from the verge for convenience purposes and treatment purposes. So the point to be noted here is that anything in the last 5 centimeters, 100%, whether it's anterior or posterior, you should have neoadjuvant therapy. I mean, there is no role for doing direct surgery in the lower third of the rectum. That is the last 5 centimeters. Between 5 and 10 and 10 and 15, we have the various guidelines based on MRI and everything. But for the last 5, which includes the 3 centimeters of the anal canal, you must have neoadjuvant. That's why we use that. So that's why I said there's a difference between what the anatomists say and what the surgeons use. If there's nothing else, I think it's a on this.
Yes.
You would get
So we
a
can wind up.
pass, except for the question on the restaging. Otherwise, you did well. Good.
Yes.
Thank you.
Thank you, Amardeep. Thank you, Ramesh, Anand, and Amanjeet Singh, and all the faculty as well. Thank you.
Thank you, sir.